All right, shall we? Sure, wonderful. Hi, everybody in Oconomowoc. And and in Madison, I understand. Hello. Hi, I'm Kelly Hoagland. I'm an adult psychiatrist. I've been with Rogers for about a year, and right now my clinical work is focused on outpatient psychiatry through a contract arrangement with Freighter Health in Menominee Falls. It's great to be here today to talk about a topic that I love, which is wellness, and with that, avoiding burnout. So some of the things that I'm hoping to cover today are sort of learning more about burnout, having us understand together what it is, recognizing some of the things that can protect us from burnout, and in that context also talking about a larger goal of overall wellness. So some of these concepts I think are going to be very, very familiar to folks, but hopefully we can talk about it together and reinforce for each other the importance of some of this. I'm wondering, did people have anything else that they're hoping to get out of this, any additional expectations that you'd care to share right now? Maybe we'll start with Milwaukee.
And nothing that, no, we just came because we wanted to see what you had to say.
Okay, great.
We're part of employee health, so we thought it would be a good topic for us to learn about.
Great, and Oconomowoc? Any additional expectations that you want to see if I can address, or that? No? Okay, and how about in Madison? Anything else?
I'm really going forward with it. This is what I was hoping to get out of it.
Okay, great, great. Well, thank you all for joining today. I think, first of all, what is burnout? I think we all have a sense for what it is, and it's one of those things, I think we know it when we see it, we know it when we feel it. Technically, you know, if we look at research that's been done in the area and how we define it, it's really looking at three things. Burnout is emotional exhaustion, it's depersonalization, and lack of feelings of personal accomplishment. So what does this mean? The emotional exhaustion, the tiredness, sometimes it can manifest as somatic symptoms, really decreased emotional resources, just feeling like you have nothing left to give anyone. The depersonalization is that cynicism that can develop, sort of that impersonal feelings towards other people, treating patients or colleagues as objects instead of human beings. Those are the things that we think about with depersonalization. And then lack of feelings of personal accomplishment. We think of incompetence, feeling inefficient, inadequate, not appreciated, that you're really just not living up to your potential. We can also see burnout additionally manifested in different ways than the definition might suggest. Sometimes we see sort of over-identification with patients, over-involvement with patients. We can see a lot of symptoms of depression and anxiety, really. Some irritability, sleep problems, social isolation, hypervigilance, poor judgment. Oftentimes in psychiatry, we see boundary violations in the context of burnout. Poor concentration, frequent physical illness, a lot of things. Anyone want to share anything else that you've seen in other people who have been burned out? Staff conflicts, maybe, another thing. Sort of low morale that can come with burnout. Certainly, burnout is something that can happen to anyone in any profession, but mental health professionals have long been known to be particularly susceptible to burnout, and that's because of the unique pressures that all of us face. And these are pressures at an individual level, but also at an institutional and organizational level. So some of the stressors in mental health that can be particularly problematic. I listed a bunch here that show up in the literature over and over again, that show up in the personal experiences that we all have over and over again. So just to touch upon some of them, there's violence, limited resources, crowded wards, sort of this increasing culture of blame sort of in our society and sometimes in mental health, sort of high demands, not enough resources, increased workload, responsibility without authority, inability to affect systemic change can be really problematic, sort of the conflict between the responsibility towards employers versus the patient. So sometimes those needs are not synonymous, we've all experienced. Isolation in mental health, the outpatient clinic I work in, the two other docs that are there full-time, they and I can be there on the same day in the exact same hallway and walk by each other's office all day long, but never actually see each other because everything happens behind closed doors. And I'm sure this happens on inpatient units too, when you could have a friend or colleague, right, in another unit next door, but never run across them unless you purposely go out of your way. Lack of feedback in work settings in general can lead to the burnout. Administrative demands, management conflicts, responsibility for patients, relapsing patients, a lot of bureaucracy. We see that in the VA a lot. People who get burnt out in that system. Dealing with difficult and hostile relatives of patients, a lot of paperwork, transferring patients, admitting patients, sort of working on that personal professional life balance and managing sort of dangerous patients that you're really concerned about, suicidality, homicidality. Having a patient commit suicide. Has anyone had that experience of having a patient? I had one maybe a little over a year ago. It's extremely stressful, just the weight of that.
I had a patient that was involved in a homicide.
Oh, goodness. Goodness. I'm sorry. So all of these things are unique challenges and not surprisingly lead mental health professionals to burn out at a higher rate than a lot of other people. Another thing to think about is kind of a mismatch between the person and the work that they're doing. So it becomes important to kind of know yourself, know what you like to do, know what you're good at, and find that match, because when that match is not there, the burnout is more likely to happen. I'm going to go a little bit out of order from the outline, and I'll be talking about a little bit more than I have in here. So if you're trying to follow along, don't be surprised if it feels a little more difficult than you'd expected. So what is the scope of the problem? It's a little, because burnout can be defined in different ways. It's difficult to quantify, it's difficult to assess, it can be really challenging to study, so we don't have a lot of empirical data. But there's a lot of observations and at least some studies in the literature, in addition, again, to the personal experience that all of us has. Scales have been developed to actually measure burnout. There's a Maslow burnout inventory scale, which is technically the gold standard, and it really focuses on elements of burnout, those three elements that I had just talked about when we think about the definition of burnout. Rates of burnout among mental health providers, annual rates vary in different studies, as high as 44% in one study. There was another study that showed a 57% rate of high emotional exhaustion, 42% rate of depersonalization. But interestingly, in that same sort of group of people, 59% still had a positive sense of personal accomplishment in their work. And so that piece of it is really interesting, because staff can be emotionally burdened, you can feel burnt out in some ways, yet still when there's meaning attached to the work, that can serve as a little bit of a buffer. People can sort of have that sense of intrinsic job satisfaction even when feeling exhausted, if sort of their eye can stay on sort of the goal of a larger cause that they're committed to. And in mental health, I think many people are drawn to this field because of sort of a set of values or a certain commitment to something that's harder for other people to commit to. So in general, we also care about burnout because burnout leads to turnover. There was one study that showed an annual staff turnover rate at community mental health centers of 22%, which is a big deal. I don't think Rogers has nearly that high of a turnover rate. But turnover, compromises continuity of care. It leads to organizational instability. There's financial drain involved with recruitment of staff. So we care about it for a lot of reasons. Psychiatrists more than other physicians, are prone to emotional exhaustion, and physicians in general, compared to other sort of professions, have a higher rate of suicide. And burnout, sort of in medicine in general, is associated with medical errors, lower patient satisfaction, longer post-discharge recovery. So again, that's just when the provider is burnt out. So for all of these reasons, it's a really important topic for all of us to consider and focus on and attend to.
I have a question about, say, partial patient versus inpatient versus residential patient populations in of themselves. Did they do studies where burnout is more significant in one area over the other?
Yeah, the question is whether when looking at sort of different treatment settings, inpatient, partial, hospital, outpatient, whether staff might be more likely to burn out in one setting versus another, whether studies have been done to look at that. And I didn't come across any. Doesn't mean they're not there. There's a lot of studies that look at, for instance, different practice styles, different patient characteristics, but I'm not sure that anyone's compared the different settings.
Okay.
I'm going to imagine that it comes down to match, and that for some people, you know, different settings feel better suited for them individually, and that the match is more important than the actual setting.
Yeah.
I don't know. Would be a good question. There was one study in particular that looked at 2,000 sort of multidisciplinary mental health staff, and this was interesting because 2/3 of people had sort of high emotional exhaustion. A quarter had high negative and cynical attitudes and feelings about the utilizers of their mental health services. Sort of low perception of professional efficacy, and nearly 1 in 5 in this particular study had burnout. Again, this is a multidisciplinary study. The burnout was more frequent among social workers and psychiatrists, the people who were having the most sort of face time with patients, especially people who had been in their position for 12 or more years. And this is, you know, it's interesting because much of what we know about burnout tells us that older people are less likely to become burnt out than younger people. But this particular piece of information, sort of that high level of face-to-face contact, being in that position for a long period of time, something about that seems to be particularly vulnerable. High workload was most predictive of exhaustion. Poor rewards and few perceived positive changes led to disengagement, and really a lack of participation in decision-making. Again, this is one of those organizational, institutional factors. Was predictive of reduced professional efficacy. So again, a lot of things come down to the individual, but there's also organizational things that contribute to burnout. Hello. Hello. It's your turn. Yes. We're going through the outline. It's a little bit out of order, but we're roughly on the second page, I think. So the same study that I was talking about with the 2,000 multidisciplinary staff, work group cohesion, fairness, and control best predicted burnout at the institutional organizational level. And other research, there's a lot of research out there actually that indicates that the individual characteristics are less important than the institutional or organizational characteristics, which is pretty striking when you think about it. Sort of the effect that your workplace and the workplace culture has on you as an individual to burn out or not. Yep.
Work group cohesion and fairness were higher predictors?
Yes, I can 100% understand that.
So lack of work group cohesion.
Oh, okay.
Lack of
All right.
fairness.
Yeah, I thought you were, okay.
Lack
I was
of
reading
control.
it the other way, okay.
Yeah.
Never mind.
Yeah.
Okay.
So
I was reading it the other way because those things usually are
Yeah.
indicative of, you know, a group being functional and reducing burnout. Okay. never
No,
mind.
the level of it is correlated with the level of burnout. So high levels of cohesiveness, fairness, control can be protective. Some of the individual characteristics that are important to look out for when it comes to burnout are sort of people who internalize stress, have very stressful personal or professional events, appraisal style, so glass half empty versus glass half full. Yeah. There was one day, I think it was last March or something, and when you're just so tired of winter, and I was driving to work and was just like so mad about the weather again, and I had gotten an email from Marion Hines, and the beginning of it was, wasn't this just a beautiful snowfall? She's absolutely glass half full type of person, and there are many times when I'm not one of those people. And it makes a difference, I think, in the way that you approach your work. Long work hours at an individual level, it's very, people with long work hours are more prone to burnout. And highly motivated health professionals with intense investment in their profession are at a greater risk of burnout. It's, in some ways that's counterintuitive, because you would think someone who's highly motivated and very much invested, you know, that the motivation would stay there, but really, you know, when so much is invested into one's career and into what's happening at work, can just lead to the emotional exhaustion, the cynicism, and over time, that lack of efficacy. So what are some of the protective factors? You know, as care providers, we want to know what the protective factors are. Certainly lifestyle and paying attention to non-professional life. So again, you know, trying to not be that person where the job is everything. Academic work and teaching, interestingly, has been shown to be a buffer from burnout. Collegiality, certainly, and collegiality is actually one of the more important things. Again, getting back to that organizational work atmosphere characteristic. And spirituality also, especially amongst people who are dealing with sort of a terminally ill population, a chronically ill population, sort of spirituality and religion have been found to be very important, protecting against it. So those traits that I just mentioned, those come from a lot of empirical studies. There's more sort of anecdotal evidence that just general support from peers, sort of organizational support, again at a general level, support from family and friends is important. Ballant groups, are people familiar with ballant groups? I think it tends to be more applied to sort of groups for physicians, but it's basically getting people together and talking about patients, talking about difficult encounters when it's done at a more formal level. Some psychodynamic principles can be brought in to help clinicians sort of think about their clinical skills in a different way, think about interactions in a way that's useful. And some people have shown that the ballant groups are really, really helpful for preventing burnout, in addition to general supervision. So really having someone more experienced to go and talk to about difficult cases, someone to learn from, someone to bounce ideas off of. There was a really interesting study done by this group, Jensen. It was actually in Canada, and it was specifically looking at physicians and burnout, primarily general practitioners. And general practitioners provide a lot of mental health care. But they took a look at this large group of physicians who were identified by their peers as being particularly professionally satisfied, particularly resilient. And they just sort of interviewed tons and tons of these docs to see what was it that was keeping them going in their profession. Some of what came out is what we see in sort of other settings, other pieces of literature, which is that attitudes and perspectives are really important. That sense of contribution towards other people, towards the meaning that you ascribe to your work, maintaining an interest in your work, acceptance of professional demands. So it's not just, I hate the paperwork, I hate this, but it's, well, I have to do this paperwork. Why don't I set aside these 3 hours each week to do the paperwork and get it done? And self-awareness. And self-awareness, I think, is something that's particularly important to highlight because it comes up over and over and over again as something that is really vital to maintaining a sense of well-being at work. So sort of having an awareness of oneself, what you're feeling physically, what you're feeling emotionally, what your values are, sort of paying attention to your own behaviors and having those split seconds to kind of step back and reflect and learn about yourself a little bit more. so that as you're having some of these very difficult patient interactions, you kind of know sort of how you yourself is influencing that interaction. You can, over time, become better attuned to what your own needs are. Again, getting back to this group of physicians who were particularly resilient, looking at balance and prioritization, so really setting limits, prioritizing educational needs, sort of learning through peers, and having time outside of work to do some recreation, vacation, focus on spirituality, again, other things outside of that work setting. Practice management styles, so being organized, sort of balancing workload, having good support staff, knowing how to delegate tasks that the individual didn't have to do him or herself. The collegiality, again, sort of effective use of technology and the other tools that are available to us. And then supportive relations. So this obviously comes out over and over again. It's not very surprising that having peer support, being able to consult with others, utilizing a multidisciplinary team, and then having a supportive partner, family, friends, and even sort of your own personal medical providers. In psychiatry or mental health in general, it's not uncommon for us to seek mental health treaters on our own. And in residency, it's actually really common. It used to be mandatory. It's not mandatory in most programs anymore. But just, again, to develop more self-awareness, to get the support you need around really complex issues.
Well, and also to have a handle on yourself,
Mm-hmm.
you know, and what's getting tripped by your patients of your own issues. And
Yeah, yeah. So you can be aware of things like over-identification. Where's that anger coming from when you're talking with someone? You know, maybe there's something about that's reminding you of someone else, or just a lot of things. And patients are savvy. They pick up on a lot. They really do. Many patients will know if you are not yourself, and so really taking care of yourself can be important. So again, sort of looking at protective factors at more of an institutional or organizational level, sort of feeling appreciated is sort of a positive motivating factor. Having responsibility for others, personal advancement, salary enhancement has been shown to be helpful in preventing burnout, interestingly, Paul and Jerry. Sometimes that salary enhancement, though, it comes with an added level of responsibility, I should mention. So some studies find that sometimes people put an increased demand on themselves when the figures go up. What else? Yes, the decision making. So again, when people tend to feel better, they get a better sense of personal accomplishment when they're involved in organizational decisions. So having some sort of sense of input, knowing that your opinion counts, having involvement in the process becomes very important. Interventions that can help people, assertiveness training. So again, because limit setting can be very important, helping people understand how to set limits in their personal life, set limits in their professional life, learning how to manage difficult interactions with other staff, with patients, with family. I can't tell you how many times and I've seen other people around me get caught on the phone with a family member and just not knowing how to get out of some of these really challenging situations, and sort of working with other people to develop those skills can be really important so that your time doesn't get sucked up as much, and hopefully you can sort of buffer yourself emotionally from some of that. Other interventions that have a lot of evidence for efficacy are mindfulness meditation. So I'm not sure on the inpatient units here how much mindfulness is brought in or taught, or if there are mindfulness groups that are done. I have a feeling that the spiritual care providers bring it in at some level, but any mindfulness classes. Jan, do you know?
I don't think, yeah,
Okay.
I mean, not in the real sense of, you know, like mindfulness, mindful meditation, mindfulness, you know, work, of being in the here and now, in the minute, you know, letting yourself get rid of all the other distractors. And, you know, if you're washing the dishes, focus on everything about washing the dishes. The water temperature, the soap, the feel of the dishes, the, you know, feel of the sponge, all of it, truly being there. And one of the things that I like in mindfulness meditation is there's a whole thing about walking meditation. And it combines in my head two wonderful things for people in terms of reducing stress and, you know, burnout and all that negative stuff that bombards us. And, you know, that if you can truly walk and be present in the walking and not have your head setting the grocery list or the 10 things you have to do tomorrow or the stack of laundry, you know, I mean, not letting yourself go there, but truly be aware and in the moment.
So sort of thinking about mindfulness as being in the moment, aware of what's happening in the moment, even aware of your thoughts without becoming preoccupied by them, aware of how you feel, aware of things around you in a non-judgmental way. It's kind of the premise of mindfulness. And DBT, a lot of DBT was sort of founded on the premise of the importance of mindfulness. And it's becoming sort of increasingly looked at for both its mental health benefits and physical health benefits. I think your mom is starting to work with Sarah's mom. And there's evidence too that mindful meditation leads to sort of neurobiological changes. We see increases in cortical thickening in people who meditate, better immune functioning, and again, sort of that increased self-awareness, which can serve as a very important buffer. Are there other things that people want to share that you know of either from reading or know from personal experience that are helpful for preventing burnout? Anyone care to share?
Laughter.
Laughter? Yeah. Yeah. Humor. Okay.
They mentioned like vacations, but having small things to look forward to on a daily basis, whether it's something stupid like a show that you like or going to dinner with somebody, just having something small every day to look forward to.
Other things?
I think mentoring has a big part in it. I know from schools, they assign new teachers to an older teacher. And
Yeah.
I know we've been talking about that here, but it's not happened yet. And I think that would be really valuable because sometimes you just need someone to listen. It's not necessary that you have to have an answer, that you've experienced something or saw something that's really maybe frightening or unsure of how you would respond, or just to bounce things off of other people. I don't see a lot of that here, and I would like to see more. I think that would be really helpful.
So to not only get the support from a mentor, but also to provide the mentoring and to have that sort of sense of purpose and to be able to provide support in that
I
way.
know when I have my children, the moms groups I can go to talk things over with. It's my first time being a mom, so I want to
I did the same thing.
bounce things out.
Anything else?
I think that having time to be off when you're sick, separate from PTO time, would be helpful. We all come to work sick because I don't want to be sick on the only days I have off. You know what I mean? So I think that causes a lot of stress in having to continue to function even when you're not feeling well. So if they had like separate set aside time that was just for sick time.
So ideally, an ideal way of preventing burnout is really being able to take care of yourself without sacrificing other preserved time.
Yeah.
That whole self-care. And when I used to teach nursing students and you taught people care planning, I would make them construct a self-care plan first. Because the reality is that all of us only have ourselves to give. And if we're not taking care of this person, what have we got to give to anybody else?
Yeah.
And, you know, I would stand up there and do my own self-care plan, you know, which had silly things, you know, like brushing my cat and playing with her with a light laser, pointer, and, and getting together for margarita therapy with friends, And they all thought I had 4 heads, but, making the time in a week to actually say, yeah, it's okay. The work's piled up on my desk, but you know what, I had book club tonight.
Yeah.
And there's more value to my going to book club than staying 2 more hours here and trying to erase all the papers, because you know what, there'll be a bigger pile tomorrow.
Looking at the bigger picture rather than the small things that you get overwhelmed with.
Right.
Anyone in Oconomowoc want to share anything?
I worked at a place where we became friends more than just colleagues, so we had a social connection. We did a lot of play therapy amongst ourselves. While during the working hours, in fact, one of my unit secretaries made me a pirate hat out of newspaper, stuck it on my head, and I wore it throughout the shift. Patients got a kick out of it, so did the rest of the staff. We just used to play with each other like that. It took the edge off.
It's
Kind of crazy, fun.
yeah, the humor, the laughing again. I think I've heard that the people who are most satisfied in their jobs have a best friend at work. Really interesting. It's really, really interesting. Anything else from folks at Oconomowoc?
Madison?
Praise and recognition from your coworkers is really nice.
Yeah.
And retail therapy is good.
There you go. How about Madison, our soul? Joiner.
We're going to turn the microphone on in order to talk. No, I don't think I have anything else to add that hasn't been said.
Okay, thank you. I don't mean to put you on the spot. I'm sorry.
No, it's okay.
I think, it's interesting, 2 of the things that came up were margarita and retail therapy. And it's an interesting part of our culture that sometimes, oh gosh, I need a beer at the end of the day, or let's go out for margaritas, or let's go shopping. And I don't think anyone can find fault in any of that. But one of the signs of burnout that I didn't mention before is addiction. So looking at those things, yeah, really though. Really, when people start using external coping mechanisms, whatever that is, drugs, alcohol, certain behaviors, etc., to cope.
Anything in excess.
Yes, anything in excess. Yes. Yeah. Not having internal resources to manage what's happening. So how else can we sort of protect ourselves from burnout? One is really focusing on wellness and happiness. And probably most of you in the room are aware of sort of this burgeoning literature over the past 20 years in positive psychology, which was a shift away from mental health, sort of looking at what goes wrong, why are people not doing well, how do we help people who are doing poorly, and instead positive psychology looks at why are people resilient, what makes people happy, how do we keep people who are feeling well. Some of the main pioneer in this field is Marty Seligman, and then there's also excellent work by Barbara Fredrickson. Carol Kaufman is a psychologist who actually heads up the Institute of Coaching at McLean in Boston, and she does a lot of coaching that's founded on positive psychology. There was a course taught by a professor, Tal Ben-Shahar, I think it's it? Yeah, Tal Ben-Shahar. He's a psychologist who taught a course at Harvard called Happiness, and it was the most popular course in the entire university, because everyone wants to know what makes you happy. And he actually has a book entitled Happiness, and goes through exercises. So these are the types of things that have been popping up more and more. Sort of thinking about, once the negative emotions are gone, what is left? You need to fill some of that space with positive emotions, the joy, gratitude, interest, hope, inspiration, awe, love, and really building on strengths and focusing on resilience and thriving. Marty Seligman, he's done a lot of studies to see what is actually helpful in promoting wellness, resilience, and happiness, and has developed a variety of exercises and sort of looking at everything. the 3 exercises that he found to be the most effective for people are 3 good things, using signature strengths in a new way, and a gratitude visit. So the 3 good things in life, this is actually one of my favorite things. It sounds kind of hokey, but really being able to focus some of your energy and attention on positive things. So at the end of each day, and I'll do this with some of my patients actually, at the end of each day, can you think of 3 positive things that happened during the day? And okay, so plenty of people are going to say, no, there's nothing. There was nothing good. And also, but in addition to the 3 positive things, what sort of role did you have in allowing that positive thing to happen? So really thinking about the efficacy. So for instance, even someone who can't think of anything positive that happened, maybe they even saw something positive, saw the sunset. What was their role in that? Well, they took that split second just to look at the sunset, sort of allowing that time for reflection each night. Another exercise that's helpful is sort of knowing what your signature strengths are and applying them in new ways. So believe it or not, there's a website that you can go to, and a lot of my residency classmates and I did this a few years back when we had this lecture on positive psychology. Again, it sounds kind of hokey, and the name of the website is hokey. It's called AuthenticHappiness.org. But this is Marty Seligman's website, and you can go through and take tests and sort of learn what your strengths are. So again, focusing away from the weaknesses, but onto the strengths. But then once you learn about what those strengths are, really challenging yourself to apply them in new ways. And for some people, for instance, who are really good at applying their strengths in a professional setting, but not in a personal setting, learning how to translate some of those skills, or vice versa. And then lastly, something that can be helpful for people is a gratitude visit. So again, gratitude is one of those positive emotions that we know can help facilitate happiness. And although the gratitude visit doesn't have, according to the research again, as long of an impact on people, sort of taking time to write a letter to someone to whom you're particularly grateful and sort of delivering that letter, delivering the message of your gratitude.
Or, that's a good point. Let me think about that a moment.
Carrie, what was the question?
The question was, how would the kitchen staff know to treat a severe reactions food tray differently than just a regular food allergy? I guess we'll have to figure that out.
Yeah, wouldn't that go through the HMS ordering?
Yeah, I don't think we have anything specified from a food allergy versus a severe food allergy, which is maybe something we would want to put together. So you bring up a good point, Liz. Just taking a note there so I can remember to look into that a little further.
And then their physician is one who determines this to be severe?
Correct. The admitting physician will determine that up front before the patient's even admitted while they're still in admissions. That way we can alert the unit in case it is something so severe that we'd have to wipe it down first.
When I just think there's always different definitions of severity. You know, it's
Oh,
nice
for
if the
sure.
doctor's the one saying how severe it is as opposed to.
Yeah, it needs to be the physician that specifies the severity. Not that we couldn't change that and turn it into a severe, after you learn more from parents and family, but that's what the call, the physician, we're going to encourage them to make sure they check in with the family, make sure they have all the details. So.
But Carrie, how many severe cases are we talking about in a year? I mean, this particular case, the patient never got a peanut, but it was in the air and it was a cross-contamination issue. So we're not talking, I mean, we have many, many patients that have food allergies, but it's these ones that we do have to use the bleach wipes and, you know, really do more thoughtful planning.
Right. They're seldom, which we hope continues. We might see an increase, so that's what we're, expecting, but definitely, I mean, I've only known of the one severe since I've been here for 8 years, but then again, I've been in a lot of different departments, so
I'm surprised it took so long for that to come up, because, I mean, you know, we've worked here, a few of us have worked here for a pretty long time, and I think we should always, I mean, that was horrible. Like, it was a frenzy of, oh my gosh, we have someone with allergies, why are we freaking out about this? It's a food allergy, you know, like we've never seen this before.
Right.
It was like, everything had to change. We need to continue to, you know, keep.
Universal precaution.
Exactly.
Mhm.
It's gotta be
But-
continual.
But in that case, that there are many patients who we wouldn't have had to go to the extreme with the bleach wipes and everything.
Right.
And this patient, again, did not eat a peanut.
Right.
Right.
No, well, I think the point would be that we learned a lot, and now we can implement that as needed. And we're
Right.
gonna, it'll be a lot smoother next time.
Yep.
But on that idea of, if we had somebody that was severe again, like that child, maybe we could just color code something starting way down in the kitchen, because even they will be more careful when they see that color on the tray, all the way up through the process.
That would be a good idea, is to separate the severe versus a regular allergy with the
Yeah.
color coding. I didn't know I was gonna need an assistant today. Kathy, are you taking some notes too?
I am.
All right, thank you. All right. So, the quiz, let's go through this. Number 1, food allergic reactions can occur within what time period after ingestion? C, from within minutes to up until about 2 hours. Number 2, food allergic reactions are responsible for approximately how many emergency room visits per year? 30,000. A. What body systems can be affected by food allergic reaction? E. All of them. Okay. Number 4, 8 foods, which I'm not going to repeat again, are responsible for what percentage of food allergic reactions? 90%. What are the foods that most commonly cause allergic reactions? It's actually, no,
90?
All of them do.
yeah, all of them. They're all most common. It did say on here that fish and shellfish were the ones that had the most reactions. What component of a food is responsible for an allergic reaction? Protein. What medication is used to treat severe allergic reactions? D. Epinephrine. Those with food allergies can safely consume the foods that cause allergies. Never say never, except for today. C. Patients with food allergy need to have menus in advance, so I'm going to read these are funny. They can decide what they prefer to eat. They can rotate foods to which they are allergic. They can avoid their allergen. Oh, so they can avoid their allergen. Of course, we want them to have their preferences too. It's kind of a funny question. A registered dietitian should be consulted if a patient has multiple food allergies because over here, this dietitian wing over here. B. Yeah, just like you had on the answer key in the back of your packet. Did you have the answer key? Yeah, all right. Of course, I included it because I want everybody to remember what the real answers are, and I appreciate all of your attention today. Bob?
What about, you did mention that everybody's going to sign off that they're aware of the policy. This seems like a good fit to have a very short CBL for the end of the year coming up. Are you already on board with all that? We're doing that?
Probably not.
Probably not. Is there a reason why?
We can pass that on to staff development then, once you have the policy done, and we can give them the PowerPoint, and they can put together a CBL. And then by Terry.
Well, I mean, all of our line staff need to have a, 5 or a 10 questionnaire that can say, yeah, I know the basics and what to do about anaphylaxis. I just think it's something that could be done pretty quickly in a CPL. It's good stuff.
We'll make that recommendation.
Well, you got the PowerPoint and quiz already.
Yeah. Yeah, so, and I mean, we're in January, so I would get it in quickly so that they can get it ready for this spring, by June.
And the physician orders that went to the Information Management Committee today, so that will be going out when the policy is done.
Oh, good, okay. And, we can do something at Skills Fair if we have room for a poster or whatever it might be, anything. And I'd be willing to do this in service again if it was informational enough for whomever, different shift or later on in the year again, so.
Well, if you just took this and put it into a CPL, I mean, that'd be golden. There's gonna be tons, a quick 300 or 400 people that are gonna have to click in and do it.
They could have been here today. Susan?
How was the decision made to not remove peanut products when that child was here? I'm not saying it was the right or wrong decision, I'm just asking how was the decision made? Because on first floor, I know we took all peanut products off first floor, or the obvious peanut products we took off first floor, but there was still peanut butter stuff all over the kitchen and where we serve ourselves. How was that decision made?
It was made because so many of the children turned to peanut butter as their food source, and we didn't want to deny everybody else in the hospital if we could keep it separated. That's why we have that little extra table now in our dining room. And again, the child's been in public before, so, we're hoping that we can all kind of learn to wash up after ourselves and still avoid any kind of contamination, so that's sure. Any other questions or comments? Any nut jokes? Peanut jokes? So spread the word, not the allergen. All right, thank you.